Let me begin by thanking all of you very much for being here. I am particularly pleased to welcome to Minnesota our special guest, leader of the President's Task Force on Health Reform, America's First Lady, Rodham Clinton. Mrs. Clinton, for the last 8 months, you have been grappling with a truly monumental task. Healthcare costs in the country are out of control. Our economy simply can't sustain them for very much longer. The Minnesotans who are here today have been convinced by their experiences that we have the answers to this problem. Every person in this room has been a major contributor to a real, tangible victory over high healthcare costs. The best ideas for America's healthcare system are right in this room. I can't stress enough that we're not talking about untested plans, we're not talking about academic theories, we're not talking about anything other than real life experience. If you look at the charts right behind you, you'll see that our strategy for cost containment is a winner. Healthcare costs here in Minnesota are so low, the federal government can enroll 2 Medicare beneficiaries in an HMO contract in Duluth for the price of 1 in Philadelphia with money to spare. There is nothing particularly magic about Minnesota's climate, although some would argue that, or about the Scandinavian genes or the water or the proximity to Lake Wobegon. Minnesota is winning the war for cost containment, not because we're different from other Americans, but because Minnesotans, like those here today, the healthcare providers and purchasers, have figured out how to do it right. We have pioneered right here the ideas of group health, group practice, accountable health plans, health alliances, outcomes analysis, quality measures, and insurance reform. Our approach to the healthcare market is based on the principle that if you want to contain costs, don't set the price. Improve the quality. Change the way medicine is bought and sold. Reward good healthcare providers with more business. Strengthen the power of healthcare purchasers by encouraging them to band together into private sector purchasing groups. The key is informed consumer choice, plus competition under rules that reward good behavior. All the government has to do is to set some intelligent rules for the game, clear incentives, and the local markets will devise a winning game plan. Bob Reischauer of the Congressional Budget Office was here a few months ago. Came out on the 7 o'clock flight up to the 6, so he was here all day to learn about a healthcare market. And he said at the end of that if our ideas were translated across America, we could bring the cost of U.S. healthcare down below 10% of the GNP. Mrs. Clinton, that's real savings. In other words, your problem is solved. It is happening here. And with your leadership, and I really do, it can happen all over America. Ladies and gentlemen, it is now my great pleasure to introduce one of America's most valuable public servants and a key figure in the future of U.S. healthcare, Rodham Clinton.
Thank you very much, Senator. And thank you also for the many hours you have spent with me since I started on this effort. I appreciated all of your advice and counsel and I'm very grateful for it. And if there were a way that we could have Minnesota take over the country in terms of health care, I'm sure you will figure it out and tell me before too much more time goes by. Well, I want mostly to listen. I have had the opportunity earlier to make a speech and to talk about the President's health care plan and the basic principles that underlie it. But I also stressed how strongly we believe that there is a great opportunity ahead of us in this country to begin to sort out how best to make a healthcare system work for all Americans in line with principles that are very much embraced around the country. We do want to reach universal coverage for both human and economic reasons. We do want to have a guaranteed benefits package available to all Americans. We do want to obtain savings in the system that can be better used then to allocate care and to make more efficient decisions. We do want to have choice in the system so that individuals will be cost-conscious, quality consumers that will be making choices among accountable health plans. We do want to simplify this system so that the complaints that I hear and that all of you live with because of the paperwork burden imposed on you by the public and private sector can give way to worrying about how better to improve quality instead of hiring one more administrator or clerk to fill out yet one more form. And we do want people to take responsibility for their own health care, to spread that responsibility across all of us. And there are many features of these principles that we are working on as we determine the exact direction that we should go as a country. But we have looked to Minnesota. Minnesota has advanced much further than the rest of the country in organizing care. You know better than I, you have a much higher percentage of your population already in some kind of organized care system. You have pioneered in the use of managed care for the Medicaid population. You have had a much broader network of care available in rural areas than is commonly available in many other states in their rural communities. You've dealt with the Manpower program through the University of Minnesota, producing more family physicians who will serve in rural and underserved areas than any other medical school in the country. And you have had the benefit of bipartisan cooperation in your state legislature as you have worked to perfect and improve the market forces that have moved you to the point where you are. We have looked very closely at what Minnesota has done and have learned a lot. And as I said at the earlier forum, what we want is a national framework in which certain conditions are decided by the federal government, such as what is the guaranteed benefits package every American is entitled to, no matter where you live. But then we want to get out of the way. And for some states like Minnesota, getting out of the way will be relatively easy because of all that you have done to position yourselves. But for other states, getting out of the way won't be able to come easily because they have not adapted to the changing market that you have and that are organized themselves in provider networks to be able to take advantage of a system that is waiting out there to be better utilized by both providers and patients. So we see a great future for Minnesota in the plan that the President will outline on Wednesday night. But we know that if this plan will work, we have to continue to listen to people who are on the front lines of delivering care and making decisions about purchasing care. And we have to have enough flexibility in it so that states like Minnesota that have already made the kinds of steps you have will be free to continue to do so. So it is with that hope that I look forward to hearing from those who will appear on this program, and then I hope we will have time for some questions as well. Thank you.
Thank you very much. And our first, we're going to have four presenters who all have programs or two. Our first presenter is George C. Albertson, the President and Chief Executive Officer of Health Partners, the parent company of Group Health and Med Centers Health Plan, as of yesterday. Health Partners, Virgin of Ramsey Healthcare Inc., is now also the parent of Ramsey Healthcare. His mother became author too, so is some of the answers are based in the
A
book.
book on healthcare reform, I hope you have a chance to read. It's actually it's coming out in about 2 weeks in Random House, so I'd be delighted to get your grab. Doubly delighted to be here. Thank you, Senator Durenberger and Mrs. Clinton for coming in. The point that I'd like to make in these few and precious moments is this. Healthcare providers respond quickly and intelligently to market forces. When the market rewards redundancy, complexity, inefficiency, and unrelated units of service, that's what a healthcare delivery system sells to the market. Healthcare is an economic system like any other. On the other hand, when the marketplace demands and actually buys efficiency and quality, then healthcare providers create ways of producing and selling efficiency and quality. That's been the Minnesota experience that Senator Durenberger so helpfully described a couple of minutes ago. In Minnesota, we have been blessed with one of the most enlightened marketplaces in the country. Our buyers, both in the private marketplace and on behalf of government employees, decided years ago to reward efficiency by giving market share to efficient teams of providers. And the result is a marketplace in this metropolitan area that is now over 80% managed care, counting the HMOs and the PPOs. And because of this managed care market strength, healthcare costs in this area are now, as you know, 18 to 23% below national averages. And we have the lowest per employee healthcare cost of any major metropolitan area in this country. That result was created by enlightened purchasers of care. It wasn't created by rules, regulations, or laws, and it was not created by enlightened providers. It was created by enlightened purchasers who rewarded those particular qualities when they made their purchasing decisions. Our prepaid Medicare results are comparable. When providers are paid for being efficient in the Medicare area and penalized for being inefficient, efficiency results. That's common sense. It's basic economics. And it's a factor that needs to be a major cornerstone in our national health policy. Our Medicare costs, as you know, are now 22% below the average cost in metropolitan areas in this country. A reform in Minnesota, as everyone in this room knows, is far from over. The Minnesota legislature decided earlier this year to accept the Minnesota Healthcare Commission's recommendation that all care in Minnesota should be delivered through provider teams as soon as possible. In Minnesota, we call those teams integrated service networks, or ISNs. Some people in Washington are saying that provider system reconfiguration into more effective organizational structures will take many years. And I'm here to tell you that they're dead wrong. As soon as the providers know for a fact that their economic future depends on being part of an ISN or accountable care system, those organizations will form overnight. In rural Minnesota, ISNs are forming at breakneck speed, and in the Twin City marketplace, our hospitals and clinics and health plans are forming ISNs at warp speed. The ISNs will be ready for the market before the regulations that govern them are written. To give you an idea, once the providers have an understanding of where their work systems are going to be, providers are putting themselves in a position immediately to conform with the systems. So the point I'd like to make is it will not take a lot of time to reorganize the provider system if you create incentives that are real and incentives that are clear. But if there's ambiguity, or if the government makes the tragic mistake, and I was delighted here to say it didn't intend to, of trying to micromanage the process and create a template that pre-designs each ISN accountable care system, then the process will take much longer, it will be much less effective, and will be with much more resistance from the provider community. So my advice to you is to do exactly what you said, and it's basically create the rules that stay out of the way from the stampede. Two final points, quick ones. In Minnesota, healthcare reform in the marketplace have now evolved to formally reward quality as part of the purchasing decision. We're far ahead of the country in healthcare outcomes. The Minnesota Healthcare Business Action Group is a purchasing group of major employers that make healthcare decisions based on outcomes. The state of Minnesota is creating a data institute that will deal with quality outcomes. National reform should start at that level. There's no reason in the world why patients shouldn't be able to choose between health plans based on their relative success in achieving healthcare outcomes. In areas such as detecting and curing cancer, preventing preterm births, and on their heart surgery mortality rates. We're creating those kinds of numbers here, and we can do them nationally. My last point relates to the Medicare issue, and I'll do this in brief. Federal government is currently doing great damage to managed care and care efficiency in Minnesota with the Medicare payment mechanism. We're being penalized for our efficiency, with payments actually dropping next year in this very county in which we're now sitting. We're paid in this county right now $335 per month for our Medicare patients, and that number will shrink. In New York, as a contrast, where health delivery is much less efficient, the government now pays over $500 compared to our $335, and that New York number will jump 15% on January 1 to nearly $570 per month. So the most efficient market, they're shrinking their payment. In New York, they're increasing it to $570 a month for nearly double theirs. That isn't fair to Minnesota seniors, and it isn't good government policy, and it will force us all back into fee-for-service Medicare with all the implications that involves. But get off the Sorry, note, I'd really like to thank you for coming to Minnesota. Thank you for coming here to hear what we have to say. And we really do wish you the best in healthcare reform.
Can I ask you a question?
Sure.
One of the issues that we're struggling with, and we would welcome your input on this, is how to ensure that the currently uninsured, once there are payment streams for them, the Medicaid patient, those who have traditionally been cared for in non-organized networks, and with very few exceptions, will be able to join the networks on the same basis as any other consumer. I spent the morning at one of your community health clinics, and that is their big concern. I mean, they are very concerned that their clientele will still somehow get left out, or that the rules will be written in such a way that they will be ignored and all the rest. And the second part of that is how you will foresee within the integrated networks cooperating with the existing public health infrastructure like community health centers, if that is something that you're developing plans for, so you can figure out how to provide care to those difficult to serve patients that traditionally have not been part of organized delivery networks.
Those are two important questions. In Minnesota, we've been also pioneering a Medicaid prepayment, as you probably know. And so we have some strong Medicaid prepayment plans. In Ramsey County, in Castle County, but Ramsey County has been a very exciting prepayment program in general assistance medical care that takes care of some of the people who aren't covered by Medicaid. It takes care of them on a prepaid basis and does an excellent job doing that. Our strong belief in Minnesota has been that all care systems should be accountable for doing their fair share and should be growing with populations, and as you said a while ago today, that should be invisible to the recipient. The benefits are the same, the care will be the same, and the system will be the
So
same.
would you suggest then, as part of the federal guidelines that would be applicable nationwide, there would be some definition in the accountable health plan that there has to be some, not only openness, but responsibility for enrollment?
Absolutely. We think that everyone ought to do their fair share in those marketplaces and serve the population equally.
Thank you.
Thank you.
Bert, thank you very much. Kind of hard to know what to say when the First Lady of the United States of America says, may I ask a question? I guess that's why we're here, right? Okay, Dr. James Anderson is the President and Chief Quality Officer of Health System in Minnesota. He's the board-certified rheumatologist. I got to tell you, he has the same answer to the question all the time. The answer is always tendonitis. We were playing golf, and I said, my elbow is going to pop. And he felt it, and he said, that's you got a torn tendon. Yesterday, we were having lunch, and Susan said, I've got this sore shoulder here. It's driving me crazy. And then he said, well, do this, do that, something like that. He said, well, that's tendonitis.
You're right. And Senator, the advice in both cases was worth what you both paid for. Fellow conspirators in the Minnesota healthcare system, the nation's leaders are contemplating a dramatic change in our nation's healthcare system, the American Health Security Act. If this change is to succeed, it's going to require active and enthusiastic participation by our nation's physicians. And as they contemplate their response to this change, I'm reminded of what George Bernard Shaw said when he said, "This is the true joy in life, to be used for a purpose you consider a mighty one, to be a force of nature, rather than a feverish, selfish clod of ailments, complaining that the world will not devote itself to making you happy." Simply stated, if the proposed change is to succeed, physicians cannot choose to become a feverish, selfish clod of ailments. The experience of Minnesota's integrated care systems, such as the Mayo Foundation, Health Partners, Health System Minnesota, which is the integration of Methodist Hospital and Park Nichols Medical Center, and many others. These kinds of systems provide real encouragement and some useful and even provocative advice to the architects of the American Health Security Act, and also to this country's doctors. And the advice can be summarized as follows. First, Integrated care systems, such as multi-specialty group practices, can not only control costs, but they can also improve quality. These models give no reason to fear that promotion of these types of systems will impair the health of Americans. The second point is that to the extent that health reform perpetuates compartmentalized piecework payment systems, these archaic systems will inhibit the innovation and collaboration that are going to be vital to the success of reform. We need to focus on how doctors are paid, much more than on how much doctors are paid. The third point is that while measurement of quality is vital to improvement, there's a dark side to data. If data on health quality are used in a fear-based system of inspection or fear-based system of punishment, rather than for improvement and for learning, reform will fail. Now, these 3 points can be supported by data and by examples from Minnesota's major integrated care systems, and particularly from those systems which have multi-specialty group practices as their core. The quality record of these systems is truly impressive. In Park Nicollet, the system I'm most familiar with, for example, detects 96% of the breast cancers in the system in a curable state. Group Health has extraordinarily low premature birth rates for infants. Mayo Clinic sets benchmarks for hospital mortality despite hospital costs which are well below national norms. And these results are obtained without the use of externally imposed standards, regulation by plan managers, or Captain May I sort of inspection systems. They're obtained by physicians working together, as Shaw would say, for a purpose they consider a mighty one: better care for their patients. If the American Health Security Act promotes the nationwide development of systems such as these, it need not fear that the quality of care for Americans will suffer. The second point, that compartmentalized piecework pay, perhaps best exemplified by the Medicare system, is a profound inhibitor of innovation, best illustrated by an example. A couple of years ago, Park Nicholas doctors implemented an inexpensive new technology. I know that sounds like a non sequitur, but it truly is the case, called mammotesting in the workup of women with breast cancer, or possible breast cancer. Compared with traditional methods, you have to understand that the mammotest device is able to biopsy breast abnormalities with greater accuracy, at 30% lower cost, and far less patient pain and suffering. Most important, it shortens what we call the sleepless nights factor, the time between when a woman is told she might have a problem to the time when she has a definitive answer. So what's the problem? Why hasn't everybody heard about this technology? Why isn't it all over the country? The problem, simply stated, is the piecework reimbursement system by which American, Canadian, and virtually all of the world's doctors are paid. Breast biopsies are done by surgeons, about $40,000 per year per surgeon in fees. This new mammotest procedure, on the other hand, is done by a radiologist. So, if you're going to implement this real quality improvement, each surgeon in a piecework reimbursement system would have to transfer up to $40,000 to a radiologist. Is it any wonder that this technology has not been widely implemented? And this is but one example. In conversations that I've had over the last several years with over 100 real doctors, I call them, real practicing doctors, I've repeatedly heard that they would innovate on a massive scale were it not that the piecework reimbursement system forces them to choose between better care and economic disaster. These are not bad doctors. This is a bad system. The third message from Minnesota's integrated care systems deals with data. Our experience in the Institute for Clinical Systems Integration, which is a collaborative effort of 21 large employer groups, the Business Healthcare Action Group, health partners, Park Nicollet, Mayo Clinic, and dozens of smaller primary care practices, it's taught us that W. Edwards Deming was right. We must drive fear out of the system if we're going to succeed. The Institute's mission is to make our various practices into a living laboratory for the continuous improvement of health. And so on a huge scale, we are designing, implementing, measuring, and then redesigning guidelines in a never-ending cycle of improvement. The measurements that we generate, measurements of conformance to guidelines, measurements of outcomes, measurements of total cost, They're generated for one purpose and one purpose only, for improvement. For example, we won't use the measurements to rank our physicians' performance and then publish the rankings, an idea that's widely circulated as a great thing for the marketplace. We already know that for any of these measurements of our physicians, 50% of the physicians will fall below the median. That's a relentless fact of statistics. But how would the doctors who are below the median feel? How would you feel? What improvement purpose will this ranking serve? Just one small example of the dark side of data. Were we to use measurements for these dark side purposes, we guarantee that the majority of physicians and clinics and hospitals' efforts would go into attacking the measurements rather than into improving processes. We caution the architects of health reform not to misuse data in this way. To do so would be to ensure that our nation's doctors would become a feverish, selfish clod of ailments. In summary, Minnesota's integrated care systems give encouragement to health reform designs which are based on competition among truly integrated systems, provided that these systems are allowed to use physician payment systems which encourage innovation and are also free to use data for improvement rather than for fear. Under these circumstances, our nation's physicians will be a powerful force of nature working on a purpose they consider divine. Thank you.
President, Chief Executive Officer of Fairview Hospital and Healthcare Services.
Well, I got a name changing that day, but
I know.
this is Clinton. I'm Richard Bartley, Senator Durenberger, and distinguished audience. Thank you. It's a privilege to be here. I've been asked to focus on hospitals specifically and how they're adapting to competition. We spend a little bit of time on what has been occurring, and then I'm going to do a little prognostication into what I think is going to occur with hospitals. May have a few differences of opinion with Georgia, but that's not totally unusual. I have 15 years of experience in Los Angeles, and I've been here now 4.5 years, so I have a pretty good comparison base. In two more different environments one could not imagine. Opposite ends of the chart, so to speak. I'd like to talk to you about my observations of the Minneapolis-St. Paul market compared to based on my Los Angeles observations. Here there's been remarkable progress in the voluntary hospital capacity reduction, specifically through the development of multi-unit systems. Tremendous numbers of hospitals and unnecessary capacity has been taken out of the system in a voluntary fashion without any need for any kind of external influence. In Los Angeles, that's yet to come, and it's going to be a very troubling situation. Also here, there's tremendous homogeneity in physician practice. Remarkably and consistently high quality among the physicians, be they in group practices or be they in independent practices. Our data shows no significant differences within Fairview in terms of the mode of practice and how it affects the overall quality. There's heavy competition here, intense competition. But there's also a tremendous community spirit and collaboration and attention to community benefit type issues. A number of excellent examples of that which I won't have a chance to tell you about. The market is dominated by very large payers. This is a state with about 4 million people, almost 2.5 in this market in the greater Twin Cities area. We have 3 payers with over 500,000 enrollees. In LA in particular, the approach to dealing with providers was to heavily leverage the purchase of individual pieces of care, and I think you've heard that theme. The other aspect is what I call retroactive inspection. A major reliance on inspecting the system after the fact. So purchasing pieces, inspecting after the fact. It's better here, but it needs to get a lot better. And I think it will. Hospitals and physicians are relatively efficient here, and I think some of that data speaks for itself, so I won't go over that again. And I think much of that is the influence of managed care. The other trend that's very interesting here that I have not seen in Los Angeles was what I call increasing consolidation on the physician side of the business. Existing groups are growing. Physicians and hospitals are coming together, seeking a common approach to try to improve care. Small practices are joining associations, are merging together. And we're seeing another trend here, which is that systems are increasingly acquiring primary care practices. That may or may not be a good trend, but it certainly is occurring because an emphasis on primary care is clearly there. In terms of major influences on hospitals and on the I'd like to suggest that there are indeed enlightened providers, and that there really is a professional need to be part of the answer, and that really does motivate a lot of people and a lot of my friends in the audience here. I agree that what I call informed purchasing in our business healthcare action we've experienced here in the Minnesota Employers Association for the smaller employers. Two excellent examples. I think in this last year, I've never seen more advances in physician-hospital integration and movement towards trying to create value as a team. I think I've seen more in the last year than in my entire career. And I think much of it was stimulated by the request for proposal put out by the Business Healthcare Action Group. So the informed purchasing, I think, is tremendously powerful. Minnesota Care has been a powerful influence, and the prospects of national health care reform obviously a powerful influence. It was suggested that our senior senator belongs in this list also, and I tend to agree. What's happening now is what I call an accelerated move to system integration, exactly the theme George was sharing with you. Hospitals, in effect, are seeing rapidly declining admission rates and length of stays. Even in this market producing those results, we've had another trend dropping even further, so when that data is updated, it's going to look even better. I think a lot of that is almost the Hawthorne effect. Someone starts practicing in a certain way, people see it, they pick it up, it adjusts. We're seeing consolidation, we're seeing closures, we're seeing consolidation of clinical programs, a rapid move to high-tech ambulatory services, reprogramming and retooling hospitals to be more day hospitals, rapid turnaround of high-tech procedures, recovery capability, but in and out. The issues we're facing are of tremendous facility, technology, and system capacity planning and getting cost structure out of our facilities. We've seen studies nationally that says there are perhaps twice as many hospital beds as there need to be. I think that's probably true. I think it may very well be true in this market. We are actively addressing trying to get that capacity out in a meaningful fashion. We're influenced heavily by continuous quality improvement. And in fact, what we're trying to do is reconceptualize ourselves from hospitals and hospital holding company type models to being operating health systems. That means we need to lead with primary care, and hospitals basically take the back end. They're at the bottom of the food chain, so to speak. They need to be retooled. They are the non-growth part of the industry. We're taking, in terms of integrating with the payers, we really need to take a process look. We need to understand who needs to do what. The white space between the two sets of functions, the paying function and the providing function, needs to get integrated. It needs to get obliterated. The customer focus aspect of CQI is tremendously important. Hospitals are a lot like Maytag repairmen. Basically, with the admission rates in this community, the average person enters a hospital once every 11 years. So you very much feel like Maytag repairmen in terms of your ability to be close to the customer. Nonetheless, primary care physicians see patients 4, 5, 6 times a year. So an integrated system needs to lead with that which is closest to the customer. What we need here, what I think is occurring, the kind of breakthrough thinking that needs to occur, is to basically obliterate the existing set of systems, processes, and particularly organizational boundaries. So your efforts with regard to antitrust are very important to us. We need to reconfigure ourselves as an integrated health system, focusing on managing our capacity, re-engineering our core processes, being involved in relationships that have joint elements of risk and reward, and then having the dollars to make the necessary infrastructures to make the changes that are needed. In effect, we're going to reemerge as accountable health systems. We're going to be emphasizing community health status and control of the premium dollar. It's going to be quite a challenge.
Thank you. It's a real honor to be here. As mentioned, I'm the Executive Director of the Northern Lakes Healthcare Consortium and also the Minnesota Center for Rural Health. Four of our organizations are healthcare networks serving Northeast Minnesota, Northwest Wisconsin, and the Upper Peninsula of Michigan. The latter is a statewide body that is helping build healthcare networks throughout rural Minnesota. I've also assisted in the development of rural networks in 6 other states. I'm going to speak today about some basic principles involved in the development of rural health networks and then provide a brief overview of my own network. Ira Moskowitz of the University of Minnesota's Rural Health Research Center has recently identified 127 rural health consortiums in this country. He notes that the organization structure of these organizations varies widely depending on the goals and characteristics of the participants. Here in Minnesota, the Northern Lakes Healthcare Consortium has been in existence since 1985. Now includes 30 hospitals, 28 nursing homes, and 43 medical clinics. As such, its diverse multi-state membership makes it one of the largest rural health networks in the country. Over the past 8 years, the consortium has developed a broad range of programs and services for its members. While cost containment has been a goal, most of the consortium programs have focused on expanding access to services for rural citizens. 4 of these programs become national demonstration projects. For example, we piloted the Rural Health Transition Program that Senator Durenberger introduced as federal legislation in the late 1980s. We developed the nation's first nursing home cooperative, and we developed the first regional long-term care and ambulatory care quality improvement networks. In effect, the consortium has become a regional problem solver, designing and funding the programs, and timely response to identified needs. While our membership includes a diverse range of organizational sizes, it's apparent that consortium programs are particularly important to smaller rural communities that otherwise would not have access to needed technical resources. Our collective size also gives those smaller entities enhanced bargaining clout and helps them work out win-win relationships with larger organizations. It's important to note that outside resources help to provide initial means to bring the providers in our network together. Resource needs include an impartial process facilitator, staff to coordinate the project, gather information to ensure follow-through, and legal, financial, and technical expertise. Another critical factor in our network's development was adherence to an explicitly defined planning process. The step-by-step, highly interactive approach built momentum to improve energy and culminated in a collective decision to create the network. During the course of the planning process, the consortium founders learned about other rural health networks and talked with their members. Consortiums in southern Wisconsin and northwest Washington, for example, served as models for what might be accomplished in northeast Minnesota. This participant education was of great importance. The identified benefits and knowledge other rural providers have been successful in networking helped to build commitment and provided additional incentives for network development. Obviously, in today's rapidly changing healthcare environment, other incentives for networking might be because networks are mandated, because network third-party reimbursement is superior, or because other networking incentives are built into new legislation. These incentives should result in an even greater proliferation of rural networks. But it's important that network architects observe the basic principles in network development in order to maximize overall effectiveness. In designing our development process, ample time was allocated to build trust among the consortium's founding fathers so they could feel confident that win-win situations could be achieved by working together. This trust building is extremely important, but an absolutely essential task in the formation of any network. For this reason, it's imperative that networks be developed from the inside out rather than dictated from the outside in. We simply cannot mandate trust, nor can we design networks from the outside that logically fit certain areas. Cookie-cutter approaches will not work in rural America. We must provide maximum flexibility at both the state and national levels. It's also important that time be allocated for fledgling networks to get off the ground and to become mature. This may take years to accomplish and will require the patience and perseverance of the founders. More networks have failed from unrealistic initial expectations than perhaps many other single reasons. Rural networks seldom produce immediate, tangible payouts. In summary, building effective rural networks require the education of participants and identification of benefits to provide the will. A carefully defined process to provide the way, sufficient financial and technical resources to provide the means, adequate time to build trust among the participants, and finally participant commitment and follow-through to ensure the attainment of mutual goals. Network development is a major national and state strategy to ensure continued access to healthcare for rural citizens. Here in Minnesota, we've developed the concept of integrated service networks, which in principle have a sound basis for success in rural areas of our state. I'm presently involved in the development of an ISN in east central Minnesota, where all the providers along the I-35 corridor between the Twin Cities and Duluth are coming together into one network. This includes the Chippewa bands and Indian clinics located in the area. The network's ultimate success will depend not only on the wisdom, perseverance, and financial resources of the founders, but also on whether or not the ISN rules currently flexibility, time, and startup resources necessary for rural networks to emerge and operate in parity with larger urban-based networks. The history of rural cooperation with electricity, farming, and most recently public schools provides evidence that cooperative healthcare networking is feasible and will be good for rural America. It's important to reemphasize, however, the design and development of rural networks should be from the inside out, with maximum flexibility within the broader framework of national and state healthcare reform. Thank you very much for the honor of appearing here today and for the opportunity to make this presentation.
We're going to give Mrs. Clinton an opportunity to ask other questions. Before you do it, there's one of the finest people in Minnesota is here with one of the toughest jobs, the chairman of the Minnesota Health Access Commission, Tom Swain. Tom, here. Tom, would you stand up? Tom thought he was retired once, and the governor brought him back and put him right in the middle of it. So, but let me just thank all of the four of you for your presentations and for the time that we went into the representative nature of the presentation.
Well, let me echo that. This was very helpful, and I appreciate the time that you spent doing this. One of the things that strikes me very clearly is the comparison that we heard between Los Angeles and the Twin Cities. And one of the problems that we face on the national level is creating a system and trying to move people in it much more quickly than people in Minnesota had to move into the system. And we can point to Minnesota, particularly the Twin Cities, as a model, but the roots of this go deeply into your traditions, your experience, and some of the leadership that you had many years ago. Let me just ask, if I could, based on your comparisons with Los Angeles and the Twin Cities, how much can we short-circuit that process? Because there is no market for healthcare in a place like Los Angeles. It is not a market system. And one of the great debates that we will be having over the next months is there will be a number of people who will talk about a competitive marketplace approach as though there were a market there that could be refined, and in very few places in the country is there a market. So we're starting from a base in which we have to create conditions to create a market, and then we have to have a market that can compete and organize itself. And I just hope that all of you in this room understand how far behind the curve many, many places in the country are. So what would be your advice or guess about that?
Well, again, I think they are diametrically opposite. I think in, for example, Los Angeles, as I recall, the largest single payer had perhaps 9% market share as compared to the dynamics here, where there are very large payers, and there was nothing approaching the kind of informed purchasing and purchasing alliances that are occurring. I'm still on the board of PPO out in Los Angeles, didn't recently go back and see folks. And what's happened there is a tremendous consolidation of medical groups. There are medical groups out there that now have, I think, 350,000 capitated lives, in a sense of tremendous capacity there. So there are dynamics occurring more through physician initiation there, I think, than through either consolidation and power of the plans, or certainly not from the hospitals we got through. I think it's going to come in different ways in different places. I've pondered whether what's here is transferable. I think a lot of the concepts are, but I think it just needs to play its way. And there are opportunists out there who are taking tremendous advantage of this, and hospitals are going to close in large numbers very quickly out there, in my opinion.
Well, that's one of the real dilemmas we face, because we have so much opposition, not from people who have any stake in the existing system, but from people whose mindsets are such that it's almost impossible for them to imagine anything different from what they have. And the possibility of hospitals closing, even though that has to happen, is enough to stop reform dead in its tracks. And there are other examples like that. I mean, the very important messages that we got about quality, there are many parts of this country where you don't have 2% of the patients in organized networks yet, and where physicians, because of their own experience, are highly resistant to any kind of organized network of care. So the different patterns that we're dealing with require us certainly to be flexible, but if we believe that we want to move New York or Los Angeles to be more efficient, then we also have to do some things that will encourage physicians and hospitals to help articulate to consumers why these moves are good for them. And that's going back to the George Bernard Shaw challenge. I mean, how can we utilize the experience here in ways that will help support your colleagues around the country who are hospital administrators, physicians, et cetera, who are very threatened by, they say to me all the time, Minnesota is different. Minnesota and Hawaii are different. Hawaii is an island and Minnesota is Scandinavian. And therefore, there are no lessons. I cannot tell you how many conversations I've had like this. So it is something that we have to be very conscious of to try to help move people to some point of understanding, because these Medicare figures are clear examples of what can happen. But I can tell you right now, and the Senator knows this very well, I could not get one member of Congress from any of the high-priced states to believe that you have lower rates because you're more efficient. It's because you are whiter, healthier, work harder, characteristics that they believe determine the outcome. And so we have such an educational job in front of us. But any advice you got, I would certainly like to hear.
Clearly the issue is incentives. You try to structure the system, create the rules, and lay the framework that way carefully delivered. The resistance in the healthcare delivery system will be immense. If you say that in order to participate in a large purchasing pool, you have to be structured as an accountable health plan, and that pool will exist 2 years from now, it'll be 50% of your market. In those 2 years, the hospitals and providers will form the system, and they'll come to Minnesota with transplant technology. If you try to mandate the technology transplant, it won't work. If you create the incentives, they will then look for the tools to meet the incentives, and the tools will be here and a couple other places in the country. The trick is not to force them into a particular model, but to say that the marketplace is going to reward particular behaviors and particular systems and then let them form. If you look at Hospitals Magazine, providers are very heavily business oriented. If you look at Hospitals Magazine, it's not about care. The entire magazine is about financing, organization, market share. This is not a new concept. We just have to change what the market pays, and then the providers will organize it.
But then we have to get big enough pools, number one. The purchasing pools have got to be big enough.
The marketplace has to get their attention, and it has to get their attention. In Minnesota, as I said at the beginning, we've had remarkably enlightened purchasers. And because of that, the enlightened providers have been able to flourish.
Well, but see, one of the problems that we've got to overcome is just even get to that level of agreement that that's the direction that we go, because there will be an enormous amount of pressure to keep the market fragmented, because the purchasers in most parts of the country still think they can beat the system, whatever the system is, and that there will not be an advantage to be in large pools because somehow that will lose their capacity to influence the care. So we've got a lot of preliminary arguments to make with people before we can get there.
Right, it's probably a compromise level in the middle where the pools are big enough to get everyone's attention and force the restructuring. In Minnesota, we talked about the Business Healthcare Action Group. That's a very large pool, very large people. But in total, what percent of the market does it see? It's 10% of the market. 10% of the market made a huge impact and have a lot of work. It doesn't have to be 90. Once providers see patients going out the door, they'll bring it bigger.
Paul, do you want to try that?
That is how to make Los Angeles look like Minneapolis. I have two concerns here that we haven't been helpful incentives, letting them know what to do. What is happening in Minneapolis? All this that has been described is happening, is wonderful, and all that sort of thing. It's a consequence. It's not the cause. The cause is a group of us on a volunteer basis have educated purchasers how to buy. That is why these people have to respond. It is not big pools. We don't have to have pools. That's not part of the center market. We buy cars excellently. There are no car pools. We don't buy cars in pools. We buy cars because people can recognize a better car for less, and the car companies have to respond. In other words, to make us, the goal is not a sound market. The goal is health care for all people in this country. It costs a better produce the kind of incentives that George was talking about, that providers must respond in the right way. And the function of government is to make sure that those rules get installed in every market. Now, I don't have time to explain those rules. I would be happy to spend as much time as you and the brain trust would like to do. Your notion of report cards is right on the money, but if you don't have your report cards right, if they focus on services rather than results, there are a lot of technical details in which God and the devil reside here. And I'm happy to talk about it. But that is one big point, is that the role of the government, our problem as voluntary actors, has been to get enough purchasers in each market to start using these rules that the providers will have to respond. That is where the bullet power of the presidency can make all the difference. You can convene the private purchaser to do these reforms, and then the providers, seeing that they are part of the right purpose, will begin to respond not only business-wise, but in their hearts as well. Okay? Now, the second thing is, I feel that what's going to happen is the way we set up the plan now, you're going to need 30 to 90 billion in new revenue. We don't have that. Not if you want to reduce the debt, to do all these other purposes. And so what I fear is that we're going to gridlock on this thing over money. Then what are we going to do? Is this going to become another 30 years of doing nothing while we argue what to do? I think there is another way to proceed to implementation of national health insurance, which requires no new revenue, that you can get there within 10 years without a new penny of revenue. The only reason you have to tax is just simply to redistribute it. And that if you can pursue that, you can get a common consensus, because it will never expose the nation to this massive financial hammer. That you can bootstrap your way to a national health insurance system within 10 years and be financially safe. Now, I'm confusing the time.
Let me say that we do intend to add some new money through sin taxes, and we're doing that for two purposes, both to have that the cushion of money for administrative and some infrastructure improvements, and also to send a message about health-related consequences. So, but we're not looking for any broad-based tax at all.
Let me ask another variant on the same question, and we've addressed this at the other meeting, and it's the federalism question. To some degree, really brings us together here. And over there, Paul is saying, you don't have a single payer option in every state. We face the prospect of 51 governments deciding potentially how we're going to deliver and pay for the medicine. And if in fact, in an employer basis, where in your plan, for example, you're asking employers to pay 80% of the cost of this product to give them the security, how is it possible that national employers can operate in a system in which they face 51 potentially different consequences? Now, they can operate in 1,000 markets because they understand markets. But how do they operate with the realities of 51 governments every year changing a market-based system? And I didn't want to ask you that question, Karen. I wanted to ask it of the panel, if you're willing to respond. But perhaps I can ask somebody on the panel to answer the question.
Well, clearly the large employers need some kind of an opt-out from individual state mandates. There has to be some ability for the employers that are in 40, 50 states to have some uniformity of benefits. That needs to be structured in a way so that it doesn't disadvantage the rest of the system. But the concept of some kind of very large employer opt-out makes a huge amount of sense.
And that is what we intend to do.
Yeah, a couple of questions. Bill George, the CEO of Medtronic.
I can completely agree with the 10 principles, especially the employer mandate. Hope you won't back off on that. With the expression that it's key to have employer basis and have that mandate. The concern I have is when you suggest that we could reduce General Motors costs 19% down to 7.9, that seems to me like a rewarding and efficient purchase, back to Walt's point. And the rest of it, ground out the system by causing the purchasers to become more efficient and causing therefore the providers to reorganize themselves before we let people kind of move out of their high-cost plans into government that people.
That's a very important issue. We do not intend for anyone who is currently insuring at less than that maximum rate to have to move up. You will get to keep the savings you have earned in terms of what your premium costs have been and will be in the future, either within the general alliance or as an independent and opt-out self-insured pool of some kind. But what we are trying to, part of the problem we've got is that absent some dramatic move, it is very difficult for a lot of the lower or the higher priced older industries to move toward efficiency. They are locked in ways that are very difficult to figure out how to get out of on a broad-based form. Now, we don't want to reward inefficiencies, but we want to short-circuit the process by which they become efficient purchasers. And unfortunately, given what has occurred in the last years where benefits have been used to replace wage increases, and because of contractual obligations, and because, again, going back to this mindset that we are stuck with, it is very hard to think of other ways to get that movement. But we don't intend to reward, but we do intend to try to relieve some of the burden, because as I said earlier today, a lot of the inefficient purchasers got locked into purchasing agreements largely because of contractual obligations, which other industries then took advantage of by dumping spouses and families into their responsibility. So it's just not a two-way street. I mean, some businesses have become more efficient purchasers of health care because they insure fewer people because other of their employees are taken care of by the more inefficient who have no way to protect themselves in the marketplace. So that's what we're trying to do.
We have a last question.
Thank you, Mrs. Clinton. I'm very concerned that there be some kind of public discussion to arrive at a consensus on what benefits should consist of in the extremes of life and in views of extraordinary interventions. Are there going to be any discussions of that in public terms so that we can try on form some kind of consensus nationally?
Peggy, I think that there should be, but let me lay out for you how I see this working. You know, Oregon engaged in such a discussion, and many people have praised their courage in doing so. But it's important to remember they did it with respect to the Medicaid population, not with respect to the rest of us. It would have been a very different conversation if we had all been sitting around deciding in community groups who should or should not get this prognosis, this operation or procedure, but instead, in effect, the people of Oregon did it to the Medicaid population. Now, I still commend them for having gone even that far, but we don't have a community model for engaging in this discussion. I think that will be one of the results of this kind of reform, but I don't think we can put the cart before the horse. I mean, right now, we will have a huge task assuaging people's fears about changing this system from something that, even though they don't like it, is familiar to them. To introduce into the national debate a question about who should or should not get care in the abstract, as opposed to moving to get the system better organized, get other forces at work, and in effect have those conversations take place at state and local levels with respect to plans and the like, I think is a better alternative right now, because there's only so much that the body politic, like the physical body, can take at one time. And we are going to be seeing hospitals closing. We are going to see doctors anxious about moving into different kinds of provider networks. We're going to see a lot of anxiety out there. And one of the arguments that will be used by those who want to retain the status quo is that this is all going to result in rationing, and your mother or mine's not going to get the services she needs, and to even have to try to deal with that in the abstract at this point, I think would be very difficult.
Well, the time has come to say adieu, and thank you very much, Mr. Clinton, for being here. And I know you'll be back. I know written form and other forms because of this, but let me, on behalf of everyone here, express our appreciation to you for the first bit of challenge you've taken on. I mean, there's a lot of risks in taking this on. It's incredibly rewarding as you go on, but your job has just begun. And let me say to everybody else that I heard Mrs. Clinton say today that this is a planning process. There is a plan. There will be a piece of legislation reflecting the President's view and the recommendation that's been made. There's Republican plans. There will be bipartisan plans of one kind or another. But it is critical to understand that in a bipartisan fashion, those of us who are committed to see this task done will see that it gets done. And we will see that it can get done in this Congress